Morning everyone. Today my topic for discussion is functional outcome of surgical management of non-union scaphoid. Regarding introduction, as everybody knows, scaphoid fractures occur as a result of forced dorsiflexion injury at the wrist level. Fracture is followed by compromised blood supply followed by non-union. In some cases leads to collapse and arthritis. It occurs in 5 to 10% cases with higher incidence in displaced fractures. Blood supply is from the dorsal ridge artery to the scaphoid. The treatment protocol at our institute is as follows. Delayed union is operated with headless compression screws. Established waist non-unions are operated with open repair and autogenous bone grafting. Humpback non-unions are addressed via dorsal approach. Proximal pole non-unions are operated via dorsal approach using autologous bone grafting. In case of AVN, we used vascularized bone graft with dorsal approach. The aims and objectives of my study were to evaluate the results of all the three treatment modalities in scaphoid non-union, compare the compare the results and determine the union rates and functional outcome. Regarding materials and method, all the operated cases of scaphoid non-union between August 2012 to December 2016 were included. 20 patients were included in the study. Inclusion criteria involved patients over 18 years of age treated with surgical intervention with minimum follow-up of 6 months. Exclusion criteria involved scaphoid non-union associated collapse with wrist arthritis, associated carpal instability, perilunate dislocation, associated fractures to the same limb, and patients less than 18 years of age. Pre-op planning included X-ray, CT, and MRI, followed by blood investigations and surgery as described above. Post-op care included immobilization for 8 weeks with below elbow cast, followed by physiotherapy. Patients were called for functional outcome at a later date at their convenience. The functional outcome was determined by Mayo Risk score, has 4 modalities: pain, satisfaction, range of motion, and grip strength. Regarding observations, 19 patients were male and 1 female, with maximum patients between the age group of 18 to 30 years of age. 55% were dominant hands and 45 non-dominant. Self-fall on outstretched hand was the most common mode of injury, followed by sports and road traffic accidents. Regarding fracture location, maximum patients were waist fracture, which was 45%, followed by distal pole 30% and proximal pole 25%. Regarding observations for surgeries, 3 cases were operated with Herbert screw. Non-vascularized graft was used in 12 patients and 5 vascularized grafting was done. Results of the study were: duration of healing was 3.25 months in non-vascularized and vascularized graft. Herbert screw took 5 months. Mayo Risk score was good and excellent in all 3 groups, with persistent non-union in 1, which gave poor results in vascularized graft. Regarding analysis by location of fracture non-union, mean time of union was minimum 3 in proximal pole fractures with 3.25 months, but distal pole fractures had best Mayo Risk score, which was 92.5. Regarding analysis by surgery performed, as described before, 3.25 months in both vascularized and non-vascularized graft, with excellent Mayo Risk score in non-vascularized graft, which was 90.83. Comparing our study with similar study with multimodal treatment, Raju PK did in 2011. We had 20 patients with mean injury to surgery time was 6.2 months. With Mayo Risk score of 87.75, we had 1 persistent non-union. When comparing with studies using Herbert screw only as treatment modality, we had 3 patients. Injury to surgery time was 4.6 months. Achieved union by 5 months and Mayo Risk score of 88.3, which is good. Comparing studies with using non-vascularized bone graft as treatment modality, we had 12 patients, all were waist and distal pole fractures. Injury to surgery time was 6.7 months, with mean time to union was 3.2 months, with Mayo Risk score of 90, which is excellent. Comparing with studies with vascularized bone graft, we had 5 patients, all were proximal pole with avascular necrosis. Injury to surgery time was 5.8 months, with Mayo risk score of 80. Persistent non-union was seen in one case. This is the first case of a 35-year-old with fall on outstretched hand 6 months back. Patient had a waist non-union, operated with non-vascularized graft, union by 3 months. Mayo risk score was 100. This is the second patient with 20-year-old male with history of injury 1 year back with waist non-union, operated with non-vascularized graft using distal radius as bone graft, and Mayo risk score was 100. In conclusion, depending upon the fracture characteristics, current treatment protocol gives favorable results in terms of bony union and functional outcome in all distal pole, waist and proximal pole non-union. Thank you.